Пані професорка Рут активно брала участь у створенні нейроурологічної допомоги в Україні. Місія, яка стала ще більш важливою зі зростання кількості пацієнтів з травмами спинного мозку. Як ми всі знаємо, це дуже актуально в наш час, особливо з травмами, пов'язаними з післявоєнним періодом, також і воєнним періодом. У співпраці з Medsynergy та INUS вона зробила великий внесок у розбудову клінічного потенціалу, розвиток нашого освіти та публікації статей. Разом з нею наші студенти беруть участь у дослідженні та збільшенні навіть охоплення і поширення знань серед студентів та не тільки щодо проблеми нейроурології в Україні, в нашому середовищі, в нашому медичному ком'юніті, за що ми їй щиро вдячні. Попрошу зустріти оплесками пані професор. Thank you so much.
Is this on?
Yes, okay.
Thanks for the nice words. I didn't understand a word, but I noticed by your face that they were nice words, and I recognized my name. So I know not all of you speak English, so I'd be glad that your name was again?
Karina.
Karina. So I think, Karina, you stay here and do some translation if you see that I'm talking about something.
I will try to do it.
Yeah. But otherwise, we have also there are enough. I have two Ukrainian friends. It's Irina and Irina. And they have heard my talk also a lot, and they can also help translating.
Можливо, ми можемо допомогти нам краще. Я просто переживаю, чи я зможу повністю дослівно перекласти презентацію. Добре, дякую.
Actually, a little bit to my person, before we meet the rector and the dean, you are very important to me. And I think you are very important to me, but that's not important. But you are important for Ukraine, because it's you who will face patients while I'm here. And that are mainly patients with spinal cord injury. And why that so is, you will find the answer in my talk.
Перш за все, ми розуміємо, що ми, як українці, дуже важливі саме в цій проблемі, в цій галузі. Ми будемо стикатися з проблемами нейроурології, і пані професорка Рут дуже рада поділитися своїми знаннями з нами, за що ми їй дуже вдячні.
So 22nd of February 2022 was for you, of course, a big shock, but it was also for me and for all Germans and all Europeans a big shock.
Загалом початок повномасштабного вторгнення був великим шоком не тільки для України, а для всієї Європи, і саме для Німеччини також.
I am a neuro-urologist. I'm basically I'm a normal urologist.
Пані професорка Рут є нейроурологом, тобто вона безпосередньо співпрацює і працює над цим.
Yes, and I specialized on neuro-urology. And who knows what neuro-urology is?
Чи, можливо, хтось знає, що саме означає нейроурологія?
Most German doctors also don't know.
Більшість німецьких лікарів теж цього не знає.
It's being a urologist and being concerned about bladder function and being concerned about bladder function in patients with neurogenic diseases.
Це наука, яка вивчає порушення сечовипускання, яке пов'язане саме з порушеннями на рівні спинного мозку, яке контролюється нервовою системою.
And that, of course, includes many illnesses: stroke, MS, Parkinson, and also spinal cord injury.
Ці хвороби, вони включають не тільки інсульти, порушення спинного мозку, Паркінсон, тобто це широкий спектр захворювань.
But we have also enough stroke patients and Parkinson patients in Germany, but you have far more spinal cord injury patients in Ukraine due to the war than luckily we have.
Звичайно, досі багато пацієнтів в Німеччині, які мають проблеми в нейроурології, спричинені з хворобою Паркінсона чи інсультом, але саме тут, в наших реаліях в Україні, наші пацієнти найбільш стикаються з такими проблемами нейроурології, які пов'язані з порушенням спинного мозку.
And the difference between spinal cord injured patients and all the other patients mentioned is the neurogenic bladder in patients with spinal cord injury really suffer from early death.
І мало хто помічає те, що люди з порушеннями нейроурологічними і саме з сечовипусканням, вони страждають від того, що досить рано і швидко помирають.
So it is very important to take care of the bladder, but actually my main focus is not on the bladder, it's all about the kidneys.
Пані професорка зазначає, що потрібно звертати увагу саме на сечовий міхур, і основною динамікою, темою дослідження є сечовий міхур, але її дослідження, зокрема, звертає більшу увагу саме на нирки.
And if you don't save the kidneys, and the kidneys don't say, hi, I'm dying.
Наші нирки не кажуть нам «Привіт, я помираю».
People are happy and nurses and family are happy, but the renal function declines, and only very shortly before it's a disaster, people feel tired and have all those symptoms.
Тобто ми не помічаємо проблеми з нашими нирками, всі щасливі навколо, і вже коли близько до закінчення і близько до великих страшних проблем, ми починаємо бачити симптоми, які проявляються.
And the beauty and also the difficulty in my subject of neuro-urology in spinal cord injured patient is it's preventive.
Основною темою дослідження професорки Рут є те, щоб саме як боротися, запобігаючи захворюванню, не даючи йому розвиватися надалі.
Our whole goal is to prevent kidney failures.
Основною темою з дослідження є те, як запобігти захворюванням нирок.
And why? And for that you need diagnostics.
І для цього нам потрібна чітка, конкретна діагностика.
And that will be kind of, why do patients with spinal cord injury need neuro-urology? Just me as a person or you as a future neurologist is not helping. You also need something which is called urodynamics.
І для всіх людей, які в майбутньому хочуть стати неврологами, нейрохірургами, ця тема є дуже важливою і потрібною для саме майбутнього вивчення.
How many people have ever heard about urodynamics? Please raise the hands who has heard about urodynamics.
Наскільки багато людей серед тут присутніх знають про проблем з сечовипусканням і взагалі уродинаміки?
At least some. At least some. Who has ever seen a urodynamic device? One. Where did you see it, may I ask? Oh, not device. You have seen pictures. Better than nothing. So, but that's why I'm here, because I am an expert in diagnosing what kind of problem this individual patient has.
Пані професорка Рут є спеціалістом саме в діагностуванні, якого типу захворювання це є.
And good diagnostic is a basic of identifying patients who are on a high risk or on a low risk of losing kidney.
І діагностика є ключовим моментом розуміння того, хто є з високого ризику, в зоні високого ризику і низького ризику розвитку захворювання.
And I can tell you, the first time I came, that was 2023. After 1 year of preparations, I kind of started right away after the invasion. Because you first, it's gone too long.
Означає те, що її шлях у саме розвитку і поглиблення в цю тему теж почався досить нещодавно, у 2023 році.
And when I came, there was only one urodynamic device in a rehabilitation center where they see patients with spinal cord injury.
І на той момент було тільки один нейрологічний девайс, який могли використовувати для діагностики.
They had the device and they had somebody appointed to use this device.
На той момент могли тільки деякі люди використовувати і знати взагалі, як використовується цей девайс.
With international help, Alexander Rose from England, it was set up beautifully.
Пан Олександр
Rose.
Гус. Тільки він розумів, як працює девайс, але він сказав, просто до ваших послуг ви можете навчитися, як ним користуватися.
It was basically the initiative of the WHO.
Це була ініціатива Всесвітньої організації охорони здоров'я.
With Volodymyr Golik being the boss.
Sorry.
With Volodymyr Golik being the promoter.
Так, очолював саме цю ініціативу Володимир Голик.
Golik, no? Golik, you say. And when I came there, and there was Klevan, close to Rivne, and when I came there was this motivated physician. There was a beautiful set-up machine, but after being shown one, he tried one which failed, and then he was understandably too afraid to use it.
Це було біля Рівного, і пані професорка побачила мотивованих людей, натхненних на роботу, але коли вони спробували використати цей девайс, на жаль, це провалилося, і вони не могли більше використовувати цей девайс.
And as always, the best device is no device if you can't know how to use it.
І насправді навіть найкращі прилади, які ми використовуємо для діагностики, вони нічого не означають, якщо ми не знаємо, як їх використовувати.
So luckily, with the help of an engineer in Germany I knew on phone, we got this machine working, and we did the first Urodynamic in Ukraine, kind of the third. You know, the first was with the instruction, the second one was the one which failed, and then we did the third.
Аж з третьої спроби пані професорка застосувала допомогу своїх колег-інженерів і власні знання, і вони змусили цей прилад працювати, і це була перша нейрологічна діагностика в межах України.
So this was in 2023, and half a year later, in 2024, I came back to check if he now was doing what.
Рівно через рік пані професорка повернулася для того, щоб перевірити, чи все ж таки досі працював цей прилад.
Normally I'm very nice, but sometimes I can be also very strict. The INUS will confirm.
Пані професорка досить часто може бути досить суворою, тому...
You know, I'm the mother of 4 and the grandmother of 11.
Oh, sorry.
I have to be strict because I'm the mother of 4 and the grandmother of 11.
Окей. Пані професорка, вона мама 4 дітей і бабуся 11. Тому вона знає, як бути суворою, як контролювати все.
So I'm strict like a mother or grandmother is, but I'm pushy. So, and anyway, so I went back half a year to Dmitro Radzikovich, who was in Klevan, the great guy, very great physician. And now he had done 60 urodynamics, and there were some criticism here and there, but basically they were all good.
Зараз кількість цих приладів в нас зросла до 60, і вони працюють на більш-менш нормальному, хорошому рівні.
And so now he is one of the appointed teachers for urodynamics by the WHO and the Minister of Health.
І зараз за допомогою Міністерства охорони здоров'я ми працюємо над розвитком саме цих приладів і збільшенням їхньої кількості.
And he joined me on this is my 4th trip to Ukraine, and he joined me to the 2 new hospitals we have introduced urodynamics to.
Пані професорка розширює свою сферу співпраці і залучила цього 4-го разу візиту ще 2 клініки, з якими вона працює зараз.
And so in 2020, and we also made teaching, we made conventions, we try to get this message I want to convey you today in this speech. Also, we try to spread it.
Саме тому пані професорка намагається поширити якомога більше знань про цю тему, яка зараз піднімається і про яку буде вестися доповідь.
So on our 3rd visit, then I could already visit Dnipro number 8, Vinica, and Lviv, and Klevan. So then we had already 4 sites having a urodynamic machine and being able to use it.
Після відвідання 4 міст у нас зараз є пристрої, які ми можемо застосовувати для нейроурологічної діагностики, і також як ми можемо це використовувати.
So in Lviv, they had no device, but they had some knowledge. And with the support of the German patient advocates for wheelchair people, for spinal cord injured patients, we were able, with the grant of the German patients with spinal cord injury, to buy a device for Lviv.
Вони отримали грант для лікування пацієнта у Львові для того, щоб вилікувати його проблеми нейрологічні, саме пов'язані з травмою спинного мозку, покриті німецьким урядом.
And when I met Professor Schulak, I don't know if you know him, in Kiev, he told me, oh, that's really great work, what you did. And he seemed to be like a benevolent stalker. So he knew everything where I had been, and I had never met him.
Професор Шулак з Києва, можливо, ми його не знаємо, але він був вражений, наскільки глибоко професорка Рут допомоглася, долучилася до розвитку нейроурології в Україні, і він знав про всі її візити, всю її роботу, навіть при тому, що вони не зустрічались і не пересікались.
And he requested, he said, I know you're coming here for the veterans. They're fighting for our common goal to have freedom in Ukraine. But there is the pediatric urologist, who sees a lot of patients with spina bifida. Couldn't you also teach him?
Він розумів, що пані професорка відстоює велику ціль і велику місію допомагати ветеранам, які боронять нашу свободу і наш край, і заради великої нашої спільної цілі миру в світі. Але один нейроуролог-педіатр сказав, чи можемо долучити ці знання також до допомоги дітям з незарощеними дугами спинних хребців, спіна біфіда.
And you know, spina bifida is basically a prenatal spinal cord injury.
І як ви знаєте, це пренатальне порушення, яке ми не можемо вилікувати.
Yeah, and as a mother of 4, a grandmother of 11, I couldn't say no.
І як мама 4 дітей і бабуся 11, професорка не могла сказати ні.
And actually, he's doing great. He got a Canadian machine, a machine donated by Canadians.
Вони отримали ще кращий канадський девайс, який теж може допомогти.
So that was 2025, and now 2026. I'm here now. I started in Lviv, visiting both centers, the adult and the pediatric centers. Then we went to Clevon. I rechecked, and in Clevon now they have a second machine. So we looked if this all worked, because this is the machine the new centers got, and I didn't know the machine, so I first had to be get used to the machine.
Зараз професорка Рут розширяється, і зараз, як ви могли зрозуміти, працює не тільки з проблемами травм військових, а також і в педіатричній нейроурології, і вони вже у Клевенці мають другу машину і розвиваються, вчаться, як з нею працювати.
So then with the help of Dimitro, he joined me to visit then Ternopil and Ivano-Frankivsk.
І зараз ми дуже вдячні за те, що ми відвідали також Івано-Франківськ і Тернопіль.
And so, and of course, it's much easier to have a Ukrainian trainer on your side when you're actually working with the machine.
І, звичайно, набагато легше мати колегу-українця, коли ти працюєш з цими машинами саме на місці.
And I think now I start my presentation, and we can always interrupt if somebody has personal questions to me. And please raise your hand and talk to me. So next slide. Oh, yeah, to translate. Yeah,
Зараз ми приступаємо до презентації. Це був такий короткий вступ про те, наскільки важлива саме місія професорки Рут в Україні і наскільки велика робота вже була пророблена до цього.
Yeah, I want live discussions.
Так, і, будь ласка, будьте вільними в своїх питаннях, питайте українською, питайте англійською, ми будемо намагатися перекласти, і щоб ми змогли отримати гарний конект-зв'язок.
It's your generation who is fighting. It's your generation who has to be best trained to give the best services to the veterans and, of course, to all Ukrainians.
Це ми те покоління, яке боремося, це покоління, яке має зробити Україну кращою і допомогти нашим ветеранам виздоровіти і допомогти їм саме з лікуванням.
So, next slide, Mr. Abhinav. Oh, I should maybe say that Abhinav I got to know him through the International Neuro-Urology Society, and he approached us to expand our knowledge.
Абхінав загалом допомагає контактувати з професоркою Рут для того, щоб ми саме отримували ці знання і розвивали нейроурологію в Україні.
Next. And together with Christina. Is Christina?
І Христина.
Abhinav, your colleague Christina?
Христина Гафійчук, так.
Yeah, both. So now next. Well, that's a little bit too fast. I can't. I'm a fast-speaking person.
Oh, sorry for problem.
But I'm not that fast. Okay. Now, don't look too long on this picture. That was me in much younger age when I would do a urodynamic. And this is a urodynamic device where you can do urodynamic is measuring pressure in the bladder, and X-ray looking at the bladder the same time.
На цьому фото професорка Рут в молодому віці, вона використовує девайс, який допомагає визначити тиск в сечовому міхурі і з допомогою рентгенівського опромінення саме дослідити вміст сечового міхура і кількість сечі в ньому.
And this is not really actual since last summer I'm retired, but I worked since 1998 in urology.
Професорка Рут працює в нейроурології з 2019 року і має великий досвід в цьому.
And I was a fully trained university professor in Bonn. Bonn is a former capital of Germany.
Професорка Рут працювала як проводила навчання для професорів університету Бонна. Це такий неофіційна столиця Німеччини.
So 95 to 97 I did research in Harvard on aging bladder.
За певний період вона працювала над віковими змінами в сечовому міхурі.
Next slide, please. Okay. So the definition. Neuro-urology is subfield of functional urology that focuses specifically on neural control of functional disorders of the lower and upper urinary tract resulting from acute or chronic damage of the afferent nerve pathways. So the afferent and afferent. So we said it's bladder dysfunction in urogenic patients.
Питання нейроурології вивчає саме порушення сечового міхура, яке контролюється нервовою системою від від гострих до хронічних захворювань. Визначення ви можете побачити на слайді.
Next. So, and I said something again only for repetition because that's important. The aim of neuro-urology is preserve renal function, prevent urinary tract infection. When I say prevent urinary tract infection, that is too optimistic. Maybe reduce urinary tract infections and maybe prevent urosepsis would be better.
Основною ціллю цього загалом нейроурології є запобігти розвитку з інфекції сечовидільних шляхів. І хоча пані професорка вважає, що це досить оптимістично запобігти, хоча б зменшити ризик розвитку сепсису, пов'язаним з потраплянням через сечовидільні шляхи.
When we think of the bladder, somehow we all think of peeing and going to the toilet.
Коли ми говоримо про сечовий міхур, в більшості ми думаємо про те, як ми йдемо в туалет.
But over 90% of our time, we are not on the toilet. Our bladder is calm and leaves us sitting here and watching.
Але в більшості, коли ми говоримо про сечовий міхур і маємо його на увазі, ми говоримо про його функцію накопичення сечі і утримання її в сечовому міхурі.
So our bladder is a good storage organ.
Тобто він досить місткий орган, який виконує функцію вмістилища. сечі.
And that's what we want to achieve, a good storage bladder.
І це те, що нам потрібно досягти, просто хороше утримання сечі.
We can't improve voiding.
Ми не можемо покращити сечовипускання.
And the patients in a wheelchair always come up to me and say, you know, Mrs. Professor, when can I go to the bathroom again?
До професорки приходять пацієнти із питаннями, коли я зможу нарешті ходити до туалету.
And I always say, if you can walk to the toilet.
І вона завжди говорить, якщо ти можеш йти до туалету, коли ти зможеш йти до
So
туалету.
basically that's it. As long there are exceptions, but basically if you are in a wheelchair, you can't void properly.
Якщо вже почалися ці проблеми, то, на жаль, ми не можемо запобігти повністю.
Yeah. But we want them to be dry. That's our goal. And we have measures to do so that they're not incontinent, that they're not leaking. We can restore continence.
Наша основна ціль – утримати і зберегти сухість саме від протікання і неутримання сечі з сечовим міхуром.
So, and of course, we want that they live a healthy and also a good life. I can tell you, like in Switzerland, 70% of paraplegic patients do have a normal job. So they have families, they have, they can participate in social life.
Так, і це дуже велика проблема, яка запобігає і покращує загалом вирішення її, покращує життя. І близько 70% мешканців Швейцарії з параплегією, наскільки я зрозуміла, якщо параплегією, вони страждають від цього і не можуть брати участі в соціальному, загалом в соціумі і в нормальному житті.
Next slide. So, and my role model, my hero, is Sir Ludwig Guttmann. Sir Ludwig Guttmann, and I read this and maybe you translate. When the 18-year-old Ludwig Guttmann was working as a volunteer nurse in a mining clinic in Silesia, I think that is in South England, a worker was admitted to his ward. He is paralyzed after a mining accident. And the nurse says, and he was kind of, why are we not caring for this patient? Maybe you should already translate.
Коли 18-літній Людвіг Гутенман працював як волонтером в лікарні, він побачив в Сілесії, це частина Англії, в 1917 році, і він працював, йому було дозволено мати доступ до палат, і він побачив...
You don't have to worry about him, said a nurse, he'll die in a few weeks.
Пацієнт, який мав проблему, йому сказали про те, що чому він питає, чому за пацієнтом не стежать, не допомагають йому і не лікують. Йому сказали, що він же ж помре через декілька днів.
5 weeks later, the paralyzed friend is dead, dying of urinary tract inflammation and wound fever.
І через 5 тижнів він паралізований його друг, він помер, помираючи від запалення, пов'язане з сечовидними шляхами.
And of course, now we have catheters. Patients don't die after 5 weeks, but if some of them with high pressures, which is about 50 to 70%, they die in 5 to 10 years.
Зараз має розвинена і поширена катетеризація, і, звичайно, пацієнти не помирають одразу через 5 тижнів, але навіть сьогодні пацієнти можуть помирати через 5-10 років.
So he reduced mortality from 90% to less than 50%.
Він знизив смертність з 90% до 10%.
So now you have probably a mortality rate of 60 or 50 to 60%, only guessing, but I want also to reduce it to 10% in Ukrainian.
Зараз в нашій ситуації в нас смертність близько 60-65%, і місією професорки Рут є знизити смертність, як вона сподівається, до 10% також.
And I always hope for, and he was also the founder of Paralympics.
І він був засновником Параолімпіади.
Because when you die, and if you don't need Paralympics, take some years to be a good athlete. And so he started this 1948 by renting a big airplane. At that time, airplanes were not so common. And he had 12 wheelchairs in an airport and flew them out to Rome.
Як саме відбулася історія заснування Паралімпіади? В 1948 році він взяв параплан і з'єднав його з кріслом колісним і об'єднавши так. Зараз, звичайно, цей вид Паралімпіаді не є поширеним, але саме був таким початок Паралімпіади.
And I'd be very proud if we in all these clinics will find enthusiastic Paralympic sporters we can cheer to at the Paralympics.
І професор Карут хотіла б бачити ентузіастів серед своїх пацієнтів в Україні, які б могли представляти Україну на Параолімпіаді в майбутньому.
So next, I'd be the first to cheer. And this is a couple I know, and they are the German champions in wheelchair dancing.
Так, про те, що основною місією є зменшити смертність і покращити якість життя, так що пацієнти з порушеннями нейрологічними навіть можуть собі жити нормальним життям і танцювати.
So that's, you can't solve some problems, but you can definitely make a change in their quality of life.
Звичайно, ти не можеш вирішити всі проблеми захворювання, але ти можеш покращити як мінімум життя свого пацієнта.
And that's the goal also from WHO.
І це основна мета Всесвітньої організації здоров'я.
So let's get more medical. So I already said the bladder is per se, the most important task of the bladder is storage. Of course, it's nice when we feel if our bladder is filling. And then we, of course, as a healthy person, also want to empty the bladder.
Так, і основна наша ціль, як мінімум, ціль сечового міхура – це утримання сечі, і нам потрібно запобігти саме виділення сечі до потрібного моменту, до моменту наповнення сечового міхура.
Next slide. So normal storage capacity, which we have in the bladder, is 400 to 600 milliliters.
Загалом об'єм, на який розширяється сечовий міхур під час накопичення сечі, це 400-600 мл.
And about half filling, we already feel that the bladder is somehow full.
І коли ми накопичуємо близько половини цього об'єму, ми вже починаємо відчувати повний сечовий міхур.
And normally the first urge to urinate is 300 to 400 ml.
І перші відчуття повного сечового міхура вже близько 200-300 мл.
Next slide. Then, of course, the voiding phase. In the voiding phase, we want a low resistance emptying.
А саме в цій фазі нам потрібно зменшити сприйняття пустоти, тобто зменшити прохід.
So the bladder contracts in a normal bladder and the sphincter relaxes.
Коли сам сечовий міхур, він стискається, а сфінктер розслабляється і відбувається сечовипускання.
And of course, it is wishful if you can do that at a proper place to a proper time.
І, звичайно, бажано, коли ти можеш це зробити, коли ти хочеш і де ти хочеш.
Next slide. And all this is controlled, and now comes the future neurologist, by the brain and the spinal cord.
І всі ці процеси, вони контролюються нашим мозком, і, зокрема, спинним мозком.
And there is another micturition center, S2 to S4, down the spine, who kind of switches over the afferent and the afferent signals.
І відповідальними за сечовипускання є відділи S2, S4 спинного мозку, які мають аферентні і еферентні частини нейронів.
Yeah. Okay. So next. So what we have to know, nearly every type of spinal cord injury leads to a disturbed bladder storage and or emptying function.
І більшість з порушень спинного мозку, вони відповідають за те, що порушення саме накопичення сечі або спорожнення сечового міхура.
And if you forget everything, but you shouldn't forget that it's not only quality of life, that above all, life expectancy depends on neuro-urological care.
І якщо забути всі механізми, ми розуміємо, що це не тільки про порушення на рівні певному спинного мозку, це про те, наскільки сильно це впливає на якість життя пацієнта.
Next slide. And we talked about the normal function. This is a slide about dysfunction. The storage function, if the storage doesn't function, we see overactive or small capacity bladders or an insufficient bladder closure.
На цьому слайді ми можемо побачити, як саме відбувається дисфункція сечового міхура, коли неможливе відкриття сечового сфінктера і відбувається перенапруження, перенаповнення сечового міхура.
And if we have avoiding dysfunction, we have sometimes large overstretched bladder, atonic or hypotonic detrusor.
І коли ми маємо проблеми з протікальною функцією, тобто непрацюванням сфінктера, відбувається розтягнення самого сечового міхура.
And actually, the neuro-urology don't mind the atonic and hypotonic detrusor. It's not our problem.
І загалом в нейроурології не займається вивченням гіпотонії чи гіпертонії сечового міхура. Це не їхня проблема.
I tell you later why. That's often our treatment goal. Not overstretched, but we want a hypotonic atonic detrusor.
Метою нейроурології є координація деструктора сфінктера саме.
No. A high atonic and hypotonic detrusor. I come to the only this.
Атонічний і гіпотонічний детрус.
Okay, so intravesical obstruction is a typical problem of whom? Who has a typical intravesical? None here in the room. And it's when the prostate enlarges in elderly men. That's a patient who has voiding problems because the prostate is too big.
Наступна проблема пов'язана з збільшенням простати і з запобіганням саме протікання сечі.
But then they have an organic intravesical obstruction. But when the detrusor I'm sorry, that's the bladder, and the sphincter are not coordinated, you have, of course, also a functional obstruction.
І також проблема з функціональною обструкцією, коли відбувається дискоординація детрусора, сечового міхура як детрусора, і сфінктера, який саме запобігає протіканню сечі по сечових шляхах.
You can have in non-neurogenic patients, you can have detrusor sphincter discoordination.
Тому в такому випадку ви можете мати справу не з нейроурологічними пацієнтами, а з пацієнтами, які мають проблеми з сфінктером.
Discoordination. That is typical for children. You know, you learn how to store and how to void.
Це притаманно більше для дітей, які не можуть втримати сечовипускання.
But the detrusor sphincter dyssynergia, that is what we fear, and that is a danger of the kidney. The detrusor sphincter dyssynergia.
Коли саме відбувається дисенергія між сечовим міхуром і сфінктером, і це те, що є найнебезпечнішим нейроурологічним.
Next. So you can have when you go to the flow, if you make a flow and you listen to your voiding, then it's kind of. And if you are discoordinated, sometimes you see this in kids, or in men. So this is a coordinated versus a discoordinated voiding.
На цьому слайді пояснено, як саме відбувається, коли координується та дискоординується процеси накопичення сечі та виведення сечі з сечового міхура.
But observing this only tells you healthy, not healthy. Doesn't do any discrimination what is a problem.
Ми не можемо чітко визначати, що добре, що погано. Ми можемо сказати тільки те, що здорово, а що є порушенням здоров'я.
So if you have a patient you know, you saw that I was in America in a geriatric ward, so caring for elderly. And then the professor told me, because we didn't have a Euroflow meter, go to the toilet door and just listen.
Пацієнти в геріатричному відділенні в Америці, на жаль, не мали цього пристрою для виміряння накопичення сечі сечовим міхуром, і все, що вони і виведення також. І все, що вони могли робити, це просто слухати, як їхні пацієнти в туалеті сечу випускаються і намагаються зрозуміти, як саме це відбувається.
So if somebody voice like this and has no residual urine, he's most likely healthy.
І вони порівнювали, якщо звук не переривався, то вони це вважали нормою.
Next slide.
Before next slide, who needs the translation? Because people are texting, then they don't need translation.
Oh,
Who needs translation? Raise your hand.
honestly, you said that you don't speak so much English. So
Yes,
they are too shy to say that.
definitely.
Дякую.
Okay.
Thank you.
Okay, but if you don't understand anything, then please ask. Next.
This slide.
This was I said coordinated micturition. We had that. And thank you. I got some of the words which are medical terms, and I think you did an excellent job. Because
Thank you so much.
if you don't understand something, raise your hand. So because now it gets more difficult. Now it gets more to but you are a bright medical student, so we discriminate the central and the peripheral nerve system in a suprapontine, spinal, suprasacral, and subsacral area. And the sacral micturition center is S2 to S5. And if you have a suprapontine lesion above pons, you have a neurogenic detrusor overactivity, so kind of pressures of the detrusor always rising. You basically have a cortically uninhibited bladder. Basically, it means the bladder does what the bladder wants to do, and the bladder wants to pee. It's us who don't want the bladder to pee all the time, but it's not the brain. So, and if you have a spinal cord lesion, that's what I just said. You have a detrusor hyperactivity with detrusor sphincter dyssynergia. And if you have a lesion subsacral then you have and a cauda equina injury, then you have a detrusor hypoactivity or a tonic detrusor, but often they have still sphincter control. Some have no sphincter control, but if they have a sphincter control, then we are in a much better place. That's yesterday. So neurogenic suprapontine lesions, a cortically disinhibited bladder, you find with head injury, with encephalitis, dementia, stroke, insulta. That's and if you have a spinal cord lesion, that's the main point why I'm standing here. You have any kind of spinal injury, also most of the time in multiple sclerosis. You have this detrusor overactivity and the sphincter dyssynergia. And if you have a cauda equina injury or pelvic trauma or diabetes mellitus, everything which affects the nerves after they have left the spinal cord, then you have a detrusor hyperactivity. Next slide. So, and to make it a little bit easier for people to understand, Helmut Madersbacher, who is kind of the grandfather of neuro-urology, and is an Austrian professor, a good friend of mine, he kind of created this pictogram. So if a line is thick, it means overactive. If it's thin, it's hyperactive, and green is normal. Like the suprapontine reflex bladder you see above on the left. That is suprapontine, Parkinson, stroke, head injury. You have an overactive bladder, but otherwise the sphincter is not affected. And the most dangerous form is, of course, a spinal reflex bladder. You have a hyperactive sphincter and an overactive bladder. And so like the intrapelvic lesions, they have often a normal working sphincter, only an atonic bladder. And remember, we don't expect anyone to really void normally. We want that the storage function of the bladder is working. And then these patients are kind of the idea. So next, please. Next. So first the suprapontine bladder, reflex bladder, next. This is a typical in a head injury and in a side, but also in babies, and that's easy. You know, babies have a healthy bladder, have no bladder pressure, bladder problems, but as we all know, they don't know when and where to pee. That's why we need diapers. And of course, it's more cute in little babies than in adults. And so I have got permission for this picture because that's my second oldest grandchild. So it's the control which is lacking. The reflex arch is working, but the control is not working. Next slide. See, this is a reflex spinal bladder. Next slide. And there it is that the communication with the brain, with the suprapontine control centers and the sacral micturition center, this combination is not working. And that's why detrusor and detrusor and sphincter don't work together. Next slide. And what's very important to discriminate is if it is an upper motor lesion or a lower motor lesion. And this is not, you can't say, oh, TR12, it's always upper motor neuron. And you see here, so I said, upper motor neuron is always which is in the spinal cord, and lower motor neuron is always affecting the nerves going out of the spinal cord. And this varies individually. And you can see if somebody has a lesion here, maybe the spinal cord is still stuck, maybe it's only the fibers. And to discriminate that, we need urodynamics. Is that understood? Because that is the most important slide of the whole talk. It's CNS lesion, it's upper motor neural lesion, conus caunus, and the equina lesion is lower motor neural lesions. Next slide. So this is my setting in Bonn. And so there is an X-ray, you need ultrasound, and you need the urodynamic machine is a little bit hidden behind here. There is, I'll show more pictures there. And what I like is having a nurse and a doctor working together. So next slide. So high bladder pressure. What we fear, we told high bladder pressure, but we also fear, and that's even more difficult to treat, is these low compliance bladder. So that the pressure in the bladder gets higher with filling. And so if the bladder loses its capacity to expand, then of course we also endanger the bladder. And here are some signs like, we can of course have a reflux because of the high pressure, and every urologist kind of knows that. But what often is forgotten, when am I loud enough? Yeah. When the pressure is high in the bladder, the kidneys can't work against this high pressure, whether you see a reflux or not, because there's just too much resistance, and that harms them. Many urologists say no reflux, no problem for the kidney. That is too easy. It's not. High pressures in the bladder, they shouldn't be more than 40 centimeters water, but we aim for under 20. So high pressures in the bladder are harmful for the kidney, whether you see a reflux or not. And the only way to do that is doing urodynamics. Next slide. And what are we doing with urodynamics? We measure, urodynamic is measuring pressure in the bladder, measuring, this is kind of, this got a little bit mixed, I'm sorry. It's because this is the blue one is a measure in the bladder, and we measure the bladder by putting a catheter through the urethra in the bladder. We measure the abdominal pressure by putting a catheter in the rectum. In women, you can also do that in the vagina. And by subtracting the abdominal pressure from the vesical pressure, we get the actual detrusor pressure. The detrusor pressure is the pressure which generates the workforce. But when we strain, then we also have higher pressure in the bladder, but then we have also higher pressure in the abdomen. So that's why we need both pressures to subtract the abdominal pressure. We don't care about the abdominal pressure. We only care about the vesical pressure. And to measure the real pressure, we have to subtract the abdominal pressure from the vesical pressure. Next slide. So this is how we then, we have like a filling phase. And then here, like a micturition phase, you see here the micturition, then it's a normal bladder, then of course the micturition volume rises, and we can also take an EMG. Next slide. So here is a vesical pressure, and you see here's also this bump. But if you look closely, this bump is in the bladder, but not in the rectum. Whereas this spike is in the abdomen and also in the bladder, but when you look here at the differential, you only see this, and this is an actual detrusor pressure. And this detrusor pressure makes the bladder going empty. This is a picture of a normal bladder. So next slide. So to say it only, you know, this is like a catheter in the bladder and the catheter in the abdomen. And of course, we have also a line to fill the bladder. So the bladder is empty before you start. The bladder is empty before you start urodynamics. And then you look how, when we fill very slow, 15 to 20 milliliters per minute. So it's kind of imitating the natural filling speed. And to know that we have always an accurate value, we zero it to atmosphere, because if we don't move our urodynamic machine to the moon, it's basically the atmospheric pressure is always the same, and we take this as a reference point. So that's why you see here, when it starts with 0, because we kind of opened the lines to atmosphere. We have a 0. Then we open the lines to the patient, and then we see the actual volume. And the first spike you see is we always let people cough. Or kosha, yeah? Because that's always, because they have to always do that for quality control. So it's, yeah. So PDAT is the most relevant parameter to understand bladder function. It's PVES minus P abdomen, that's detrusor pressure. And of course, we can only subtract pressures recorded to the same 0. That's why we're using the atmosphere. And the same reference level. So we put the transducers on the reference level of the bladder. We always take the symphysis as a reference point. That is even in fat people easy to touch, and then we put the references on. And that are now examples of urodynamic curves. This is kind of a normal. Next. And this is already, you see here, the flow is not right, and also the detrusor is not really right, and here there is kind of a dysenergic micturition, but otherwise there are some, you see these waves, this is always a cough. These are detrusor waves. You can already see that something is not going well. So this is like detrusor overactivity, but the absolute values are probably not. So they are, as I can see here, they are under 20. So they produce urgency. People have to go more often to the bladder, but this would be not a harmful case. Next time. So this is a difference. Now we see really big detrusor pressures. I have to see how so it's, the scale over there is 100, so this one definitely is over 60. So this would be a typical case of spinal cord injured patients. So you see these detrusor overactivities, and all this is not voiding, that is leakage. And I saw, like in one hospital, I saw that a patient was cared for by giving him a condom urinal, and because they said, oh no, he's emptying the bladder. But they oversaw in the urodynamics we did last week, then we saw that the detrusor overactivity was with 160 centimeters. So in this patient, it would have been much better to have an indwelling catheter with all the problems an indwelling catheter makes. But a condom urinal does not solve his problem. And of course, if our choice would be intermittent catheterization, but if you need a catheter in men, then you should do a suprapubic catheter, epicystostomy. So this is called leakage, it's not voidings. So next. So, and this would be like a lower motor neural lesion. You don't see any action in the detrusor. The bladder filling is now, I have to see how the scaling, it's 50. So it's probably 300 milliliters here. And there is some leakage of a weak sphincter then, but it's definitely not a leakage produced by the detrusor. Totally different way of handling that. The one, I have to really calm the detrusor down by giving them medication, typically oxybutynin or other antimuscarinics. I know Vesicar is here and Miravigon is here, so whatever, but not this patient, although he's leaking. You see the leaking, it's yellow, you don't see that so much, but it's totally different story. Same symptoms, but totally different treatment. Next. And this is something I already said, I'm really fearing is when the detrusor increases with filling. And it's you divide the difference of the volume through the difference of pressure. And the typical X-ray for that is this bladder. And you know what's lying here? What's anatomically here? Speak out loud. Not the prostate, but what is also there in women, in men and in women? The external sphincter. And this is a typical case also of a detrusor sphincter dyssynergia. And you don't see overactive bladder. You see a decrease, an increase in pressure while filling. And that's dangerous and has to be treated right away. Otherwise, the bladder wall will transform, it will be more fibrotic, it will just change and you can't reduce it. It's, you all know Botox in the face. So if I would do Botox, maybe I get less these. But if you put Botox in a 90 years old, she won't get a baby face. So, but there are so you have to catch a time when you still reverse this. Botox in the bladder is one of the main players which will change neuro-urological care. And when I first came here, a doctor said to me, Botox in the bladder, you'll never find anybody. But on the other hand, I don't want that every urologist in Ukraine just puts Botox in the bladder, not knowing if it's the right patient to put Botox in. That's as dangerous. Different dangerous, but dangerous. Next slide. And this is again an example of detrusor overactivity. It is, you see here also the flow is far too low. But this could be also just an if he is not neurogenic, it could be also just being a big prostate, because high flow, high pressure, and low flow is typical that there is an obstacle. It's the same as if you have a hose, like a garden hose, and you step, and nothing comes out. It could be either you haven't turned on the water enough, that would be like a low detrusor pressure, or the pressure is on, but you're stepping your foot on it. And then also nothing comes out. But the causes are, of course, different. And a prostate is an organic intravesical obstruction, but detrusor sphincter dyssynergia are functional intravesical obstruction. It's not so easy to discriminate, and you have to be always careful to do the TURP. Do you understand TURP? Yeah, TURP, like a resection of the prostate in patients with Parkinson. They might be completely incontinent later because they have also these neurogenic things. So that's difficult. Next. So, and another thing really too, and then it's also neurologists can explain that much better than urologists, that is autonomic dysregulation. If you have an injury above TH6, TH7, the filled bladder, most of the time a filled bladder or manipulation of the bowel, they occur that afferent signals go up. There's no real regulation, and there is a massive response from the sympathetic system. And you know what happens with the sympathetic system? The vessels constrict. This leads to high blood pressure. People have goosebumps, have sweat on their skin, and then the baroreceptors want to counter-react, and they send signals to the brain, oh, it's much too high, and then the heart rate goes down, and the inhibitory signals are blocked. So, and these signs of sweating, high rise of blood pressure, which can be deadly. It's something everybody dealing with spinal cord injury should know about, the danger of autonomic dysregulation. And these signs are called the Goodman signs, after Sir Ludwig Goodman. Next one. So, and that's why we all, if we do urodynamic and spinal cord injury, we always also measure blood pressure. And you see here, if you see the turquoise line, nothing happens in the bladder. There is no problem in the bladder, but his blood pressure increases. And the only thing, the first thing you have to do is stop the filling. We don't pull the catheter, let the bladder empty and look. And most of the time, then the problem is solved. And if not, you have to treat it. So next time. So, but I also say there are limitations to urodynamics. Look at this patient next. And you see from the filling, it's going to be it's a horrible stage. This is, we call it like a Christmas tree bladder, and the bladder is, its function is gone. And all the urine, and this way is a contrast medium from the filling, is in the kidney. But look, next. There's if you would see the urodynamic to that, you don't see any pressure rise. You don't see very little with any. So if you only look at the urodynamics, you would think this patient is doing fine, can come back next year. Next year he won't come back if nobody does something. Basically is transplant or dialysis, but transplant, and go back to the other patient. But transplant and dialysis, or even worse, anti-reflux plastics, doesn't help at all. You have to give this patient a new bladder. You have to do either bladder augmentation with bowel. You have to create, no matter what, you have to save the kidneys, or even to save them if this kidney is gone, to save the transplanted kidney. You first have to create a low pressure bladder. And we do that normally with bowels. And actually, the urologists also, you have a lot of experience with that, because that's the same thing they do with bladder cancer. But if you do bladder augmentation, you have to be very radical. You have to go really down to the trigonum and really take nearly the whole bladder out and replace it with bowel to have a low storages, and then you can save the life of the transplanted kidney. Because if you don't do that, you risk the life of the transplanted, like, I don't know, but it all depends how fast, but it's only, so.
Christmas tree bladder.
This is a Christmas tree bladder. You don't want to see that. And actually, we don't see that. Nearly all my X-rays out of that come from patients from abroad. So this is preventable. But you know, I should have come 5 years before the war started. But yeah, but you know, you now have to face that, and that's also good. There has to be good understanding on the urology side about the function, because sometimes they see that if the nephrologists see that, they see, oh no, kidney function, we'll do either dialysis or transplant. If you don't look at the bladder, dialysis, of course, you can do, but it's very, very cost intensive, and it's of course, quality of life is really reduced if you are dialysis. That's not a fun thing. So, and especially it hurts me if you know that it is preventable. Next slide. So what is we have to lifelong care, and that's of course when you are in practice, you have to know them. You will see them. They need, depending on the risk of kidney failure, they need annual urodynamic checkups. They need renal function diagnostics every 3 years. And also they need cystoscopic checkup every 5 to 10 years, because they don't have a higher chance of getting bladder cancer. But once they get it, it is more malignant. So we have to be more aggressive. And we have to educate the patient, of course, what are the signs, you know, bleeding or too often infection. So, and under these conditions, even paraplegics can achieve a life expectancy with little or no restriction. 50% of our patients in Germany are elderly who have survived so long. So this whole topic of how to deal with aging, a spinal cord injury will be for the next generation. But hopefully there will be, because then they have survived. Next. So, and I only want to say thank you, and you have met the two Urinas and Annalena Butcher. I'm supported by a Continence charity organization I now founded 20 years ago, and Annalena Butcher is kind of my research assistant. Thank you. Thank you for giving me this opportunity.
Thank you so much for your incredible presentations. It was only a pleasure to hear you. Можливо, хтось має запитання? We will collect all questions.
Yeah.
There is a question on the hypocontractile bladder. Hypocontractile bladder. So there is a question in online that what is the treatment of it? Means, is there any treatment for that? Right now, no. I know. But
basically, no is the right answer, because there are ubiquitin and parasympathetic etica, but they promise more than they hold. And among the neuro-urology treatment, we say there is no pharmacological treatment up to now. If there is some detrusor action left, neuromodulation is a good option. Also in MS patients who have more, who don't have a hyperactive bladder, but have more like a storage problem, no, not avoiding problems. So they have, and there is some detrusor left, you can do a neuromodulation.
Okay, thank you. Second question, can you explain, Professor? I think more with the neurologist, so I think you can explain more about the autonomic dysfunction, dysreflexia, more about it, little bit. For the in the spinal cord injury patient.
Yeah,
because there is one question in which
you can probably do it better than I am doing. Just start you and then I correct you.
Okay.
Because I know that you know better. He's a neurologist and the brain.
Yeah.
And I'm just a urologist.
Means there is a question, in which type of the patients you feel?
It's in spinal
during the
cord
time of the
injury,
urotype.
they have to have, of course, a central lesion. If they don't have a central lesion, they can't develop autonomically, because it is this misunderstanding of the control center and the sympathetic system. So through this manipulation of the bladder, it raises, and then the counter regulation want to decrease again, but there is already there's too little pressure here and too much pressure up here, and the counter regulations, they upregulate itself.
Okay, thank you. So any more questions? Let me ask one online participant also. Oh, and yeah, there is one more question in which they are asking that which type of patient you don't want to see, means which is more critical type of patient.
I mean, from all the neurogenic patients, the ones we can do least with urodynamics is stroke and head injury. Because they have an uninhibited bladder, you can, of course, try to retrain them. You can try, because in the first year after stroke, there are a lot of things which can really happen. And you can, like in dementia, you can make regimes so that they say, like prompted voiding. So often because of the reflex to void is still there. So maybe if you would say every 3-4 hours, you kind of lead them to the bathroom and then they void. But they can't, if they wait until they feel, they never make it to the bathroom. So they have to go before they feel something. You have to look when they leak, and then you make a schedule for them. Another good way is doing the 6 glass rule. So like they have always a glass of water, and you kind of teach them after the glass of water in the morning, they go to the bathroom. And at 11, they have the next glass of water, they also go to the bathroom. So like there is a 6 glass rule. So there are things of improving their incontinence, but you don't necessarily urodynamics help. To see if they have residual urine, you need an ultrasound and not a urodynamic. So that's the patient. We sometimes do it. We sometimes do it because we want to decide if diapers and if this training is sufficient not to leave them on indwelling catheters. Because also, so catheters are not a device to treat incontinence. So if possible, I rather tend for them to go to the bathroom, and for the leakage in between, wear diapers. Because especially in Ukraine, with so many multi-resistant germs, you should limit the indwelling catheters to the least possible. In a palliative care, it's something different.
So I think it is good for the diarrhea. She is working with the new stroke unit in the neurology center. So she can explain your treatment.
Yeah.
So I'm an internal doctor in stroke department in our.
It's not loud.
It is for online.
Oh. Okay, I can come to you.
So I'm an internal doctor in stroke department in our hospital, and actually we use only like catheterization, and that's it.
No, you shouldn't. You shouldn't. We made our own study to do trial training and to avoid a urethral, and about 50% manage without catheter. So it's really worthwhile trying. And you have to, the patient has to really be a little bit motivated, but often a catheter makes them feel more sick than a diapers, because it reduces their mobility. And mobility is something, if they have it, you shouldn't make it more difficult. And I think you should try it. You have to, the only ones who need a catheter is the ones who don't empty the bladder. And don't be afraid of 100 milliliters residual urine. It's all about the functional. So if somebody has a 500 milliliter bladder and voids 100 milliliters residual urine, don't care. And they are not per se responsible for residual urine. So you can be generous with it. But of course, if somebody has a bladder capacity of only 100 and has 50 ml residual urine, that's not alive. But you could also try to treat them antimuscarinic, but I'm always a little bit afraid of antimuscarinics in cognitively impaired patients. So you have to individually decide.
So, but in our department, we treat our patient only in acute period of stroke, yes, and after that, our patient go to rehabilitation department.
Yeah.
And in that department, like I talked before with that doctor from that department, and they said that they try to teach patient to like link without catheterization, so they work.
Okay. And maybe that is also the task of a rehabilitation center. But the thing is, if you can try before, it's good, because sometimes nurses says, and also the patient, I had a computer, now I always, they don't question the indication. Or you write it explicitly, we didn't do we would say catheter Auslass. We didn't do an outlet trial. The outlet trial has to be done. Kind of force them to try how it is without a catheter. Because with a catheter, you know nothing about the function.
Yeah.
You have to be a hero,
Thank you. And може ще хтось має запитання? Це для ТІС.
My name is Oksana Timoshchuk. I am a docent of Physical and Rehabilitation Medicine Department of our university. And first of all, nice to meet you. Thank you for your interesting information, for very nice lecture. And it was very, very interesting for me because we had no any experience in this field. And thank you for your support, for supporting of our country, for your big work for us. Thank you so much. My question is, what is duration of the Botox therapy? Yes, because
unfortunately, it's only 6 to 9 months.
Thank you.
Unfortunately.
Thank you.
You first try medication, and then the next step would be Botox.
Чи більше немає запитань? Then thank you so much, and thank you so much that you did this neuro-urology theme. It's a bit closer to us, for us students. Thank you so much. And also we have some certificates for you.
Oh, very nice.
Thank you so much.
Thank you. So I think so I understand you mainly tend to neurology, and I could prepare better for autonomic dysreflexia, but I only know how to treat it, and I'm not so much interested in the detailed physiology, but you now know that neurology is not only about brain and nerves, it's also about the bladder.
Yes.
Because don't forget the organs which attached to the nerves, right? The nerves have a duty.
Thank you so much. And maybe you have one additional minute for a photo?
Sure, always. And of course,
Будь ласка,
with Ivano, and also with the whole group, or wherever.
Yes.
So thank you,
and
everyone.
I know Ivano, we have been in close contact already. I met him now the second time, and he has been
finishing the lecture.
The International
Thank you everyone for
Neuro-Urological
attending this.
and we had a talk on BIMPO.